Hola, buenos días a todos quienes están
Good morning, everybody.
conectados a este webinar de la
We
UPS
would like to
sobre
welcome
buenas
you to
prácticas para las
PAHO
enfermedades no
webinar
transmisibles.
on good practices
Vamos
for
a esperar un
non-communicable
minuto
diseases.
más para
We are
dar
going to wait
tiempo para
1
que
minute more. We're going to give you
la gente pueda
more
conectarse.
minutes for
Mientras
people
que se
to
conectan la
connect.
gente, quiero decir
While
que
people
este webinar, como todos los webinars
connect,
de la UPS,
I would like to
tenemos
mention that this
traducción
webinar
simultánea en 3
has
idiomas,
simultaneous
en
translation
español,
in 3
inglés y
languages,
portugués.
Spanish, English, and Portuguese.
Y se puede elegir el
And
idioma
you can choose
en interpretación,
the language of
empujando
your
el botón de
preference
interpretación.
by clicking on the interpreting button.
Vamos a tener presentaciones en los 3 idiomas.
We
Así
are
que
going to
puede
have
elegir su idioma preferido.
presentations in the 3 languages,
Good
and you need to
morning and
choose
welcome to
your
everybody
native
who's
language.
connecting to the PAHO webinar on good practices for NCDs. We're just going to wait 1 more minute to give a chance for people to connect. And in the meantime, I just want to remind everybody that PAHO webinars, we have simultaneous translation in English, Portuguese, and Spanish. And as we will have presentations in all 3 languages, please select your preferred language using the interpretation button. I think we have most people connected, so let's get started. Muy buenos días y bienvenidos a la tercera webinar de la serie de la UPS
Welcome
sobre buenas
to the third
prácticas para las
webinar on a
enfermedades no transmisibles.
PAHO
Yo soy Susana
series on
Luciani
good
del
practices on
programa de
non-communicable
enfermedades no
diseases.
transmisibles de la
I
UPS.
am
Y en esta
Susanna
sesión hoy
from the
día vamos a
program of
enfocarnos en las
non-communicable diseases
experiencias efectivas en la vigilancia y salud digital para las enfermedades no
on
transmisibles. Y este
ENTs
webinar es la
or
tercera en una
NCDs,
serie.
non-communicable diseases. This
Si
webinar
ustedes no
is
han
the third
podido
one
tener la
of a
oportunidad
series.
de
If you
escuchar la
did not have the
primera
opportunity of
sesión
listening
que estaba
the first
enfocado en la
session,
prevención o la segunda
this
de
was
la serie
focused
que
on
estaba
prevention.
enfocado en el manejo clínico
And
de
the
las
second
enfermedades
series,
no
which was
transmisibles, les
focused
invitamos a
on clinical
visitar nuestra
management
página
on
web para
non-communicable
escuchar estas
diseases, we
sesiones
invite you to go to
anteriores.
our website
Pero
to
hoy día
listen
queremos
to the
visibilizar
previous
y
sessions.
reconocer todas las
But
buenas
we would
prácticas en
like
la
to
región que se está llevando a cabo
acknowledge all
sobre
the
la
good practices in
vigilancia
the
de las
region
enfermedades no
related to
transmisibles, incluyendo las soluciones
surveillance of
digitales que
non-communicable diseases,
fortalecen la
including
vigilancia.
digital
Y queremos también
strategies that
facilitar el
strengthen this
intercambio de
surveillance.
experiencias en
We
la
like to
implementación de
exchange
estrategias que
experiences
contribuyen a una
by
mejor vigilancia
exchanging
para las
strategies that would
enfermedades no
contribute to better
transmisibles.
surveillance
Y también
on
usar el
non-communicable
portal de
diseases.
la
We
UPS de
want to
buenas prácticas
encourage
en
the use on
enfermedades
the
no
portal
transmisibles.
of
Tenemos
PAHO
ahí en
on
el
good
portal
practices of
casi 40
non-communicable diseases. We
ejemplos o
have
casos de
almost
buenas
40
prácticas para la
examples and
prevención,
cases of good
control y
practices for
vigilancia de
prevention,
las
control,
enfermedades
and
no
surveillance
transmisibles.
on
Así que les
non-communicable
invitamos
diseases.
también a visitar
We
el portal.
invite you to visit
Bueno,
the
para dar
portal.
inicio a la sesión de hoy,
To
quiero
start with our
invitar al
session
Dr.
today, I
Hennes,
would like to
el
invite
director del
Dr. Hennes.
Departamento de
He
Enfermedades No
is the
Transmisibles
director
aquí en la
on
UPS, para darnos
NCDs
palabras de
department
bienvenida.
from PAHO, so he can give us welcoming words. Thank you.
Como él no puede estar en persona,
Since
él
he
nos
is
ha
not going
enviado
to be
una
here in
grabación,
person,
así
he
que
has sent us
escuchamos a Dr.
a
Hennes.
recording. We would hear him now.
No creo que tenemos.
I think that we are not getting
Es el
the
volumen.
audio.
Se va a reiniciar el video. Y
Yes, we
ojalá
need to restart
esta
the
vez
video, and let's
funciona.
hope that
Siempre es así con la tecnología, ¿no?
it works this time. This is what happens with technology.
Good morning, colleagues and participants. It is indeed a pleasure for me to welcome you to the third webinar in our series on good practices for non-communicable diseases. Today's session is dedicated to a key pillar of non-communicable disease response: surveillance, monitoring, and digital health. These areas are fundamental to guiding public policy and evaluating impact. Today's webinar highlights good practices that inspire action. Let me share just a few examples of how countries in our region are championing innovation. In Bolivia, the evaluation of essential conditions for NCD care in indigenous communities shows how surveillance can be adapted to address inequities and ensure culturally relevant services. In Brazil, there are practices that demonstrate leadership in surveillance and data use, such as the epidemiological monitoring of alcohol consumption and the strengthening of NCD surveillance through the Institutional Capacity Index, and others. While in Argentina, digital health is making a difference through telemedicine for tobacco cessation and primary care. Over in Chile, artificial intelligence is being applied to optimize screening for diabetic retinopathy, demonstrating how cutting-edge tools can be integrated into health systems. In Guatemala, an innovative health intelligence platform supports early detection of chronic kidney disease. And in Mexico, a phone application is engaging adults in alcohol prevention, combining technology with health promotion in their creative and scalable. These are just a few of the many experiences collected through PAHO's Good Practices portal, which now brings together validated cases from across the Americas. Colleagues, today's session is not only about showcasing innovation, but about learning from each other through shared experiences. I encourage all of you, government officials, health professionals, academic, civil society, and international partners, to take inspiration from these good practices. Let us work together to replicate and scale them up so that more people can benefit from early detection, better treatment, resulting in healthier lives. Thank you so much.
Thank you. Those were welcoming remarks by Dr. Anselm Hennis, Department Director for Non-Communicable Diseases and Mental Health here at PAHO. And he highlighted some of the good practices that we have identified that are ongoing in the region on NCD surveillance and digital health, as well as reinforced that the purpose of our webinar today is to share some of these experiences and to really highlight the good practices ongoing in the region and help identify what some strategies that you from your places of work can implement to improve NCD surveillance and use of digital tools and solutions. So thank you to everyone who's connected. We have almost 300 people from across the region of Latin America and the Caribbean connected, and we are thrilled to be able to bring today's program to you. Voy a cambiar a español ahora. Como esta sesión
I'm going to
está
switch to
enfocada en las
English.
buenas prácticas de
Since
vigilancia
this
de las
session
enfermedades
is focused on
transmisibles, vamos a dar
NCD's
una
good
perspectiva
practices, we're
desde
going to give you a
la
context
OPS
and
sobre el tema de
perspective from
vigilancia. Y para
PAHO
presentar
regarding
información sobre
surveillance
vigilancia
and to
en salud
provide some
pública,
information on
voy a invitar a mi
surveillance in
colega,
public
doctora
health. I
Roberta
would like to
Cacheta, quien
invite
es la
my
asesora
Dr.
en
Roberta
vigilancia,
Cacheta.
prevención y
She
control de
is
las enfermedades no
advisor in
transmisibles,
surveillance,
enfermedades de salud
monitoring,
y
and
prevención
control on
pública.
NCDs. She's going to start with her presentation.
Gracias,
Roberta, you may
Silvana.
start. Thank
Buenos
you,
días a todos.
Silvana,
Es un
and
gusto estar aquí.
welcome everybody. I am
Voy a
delighted to
solicitar
be
a mis
here.
colegas que
I
me
am
pongan
going
la
to
presentación, algunos slides que he
thank my
preparado.
colleagues if
Gracias.
they could share my presentation. I have some
Por
slides.
favor. Entonces, el plan, como Silvana mencionó,
All right.
es de hacer una visión
So
general
the
de la
plan is to
importancia
have
de
a
integrar
general
la
overview
vigilancia
on
de las
relevance
enfermedades
on
no transmisibles
integrating
en la vigilancia de salud
NCDs
pública en los
in public
países.
health for
Próximo,
each country.
Si quisiera empezar.
And I would like to start
Próximo, por favor. Quisiera dando una visión general,
by
¿no? Estamos
providing
hablando de
a
estas
general overview.
5
We
enfermedades que
have
estamos
5
poniendo atención esta semana en
communicable
Naciones Unidas. Se
diseases
está
that we
discutiendo
are
una
debating in the
declaración
UN.
en la
In the UN,
de alto
we are
nivel, y
debating
estamos hablando mayormente de 5
lots of
enfermedades,
declarations in
de
high-level
riesgo, que son
meetings. We're talking
las
about
que tienen la mayor carga en
5
la
diseases
región.
that
Pero con
are
este enfoque, con una visión
resilient
más
in the
amplia
region.
también, ¿no?
But we
Quisiera
have a
hablar
broader
de la estructura de
scope in
vigilancia
this,
en
and I would
enfermedades
like to
no
discuss
transmisibles.
the
Específicamente
surveillance
para este
structure
webinar,
on
porque estamos
non-communicable
hablando de uso de
diseases.
soluciones
In this webinar,
digitales,
we
¿no?
are trying to discuss
Y en este
the use of
contexto,
digital
quisiera
solutions.
hacer
And in
un
this
recorrido
context,
sobre cómo
I would like to
deberíamos o cómo
mention
estamos
how
devemos
should
estruturar
we
a vigilância de não
structure
transmissíveis, não? Então, sabemos que
non-communicable
vigilância,
diseases
produção
surveillance?
sistemática, periódica
We
e
know that in the
estandarizada
surveillance,
de dados para
we
as enfermidades não
use data.
transmissíveis, necessitamos dar uma
For
mirada em toda a
NCDs, we
linha de
need to
cuidados, desde a
discuss
promoção de
all
saúde
the care
hasta os
line
cuidados
from
paliativos,
health
não?
production
Há caminho
until
grande
palliative
disponível,
care.
grande em áreas
We
que
have
devemos
collected
capturar esta
lots of
informação.
information,
Então,
and
estamos não só mirando os
we
determinantes sociais
will
iniciais,
be
la carga de
checking
enfermidade,
all of
também
these
mirando
social
os
loads and
indivíduos
social
e
information.
como
We will be
eles
discussing with
lidam ou
individuals
vivem com
how
diferentes
are they
condições, não?
actually
Então,
living with
em
different
enfermidades não transmissíveis,
conditions.
não só estamos mirando
And for
as
non-communicable
enfermidades e
diseases,
muitas
we
planilhas de
will not be
Excel em
focusing
separado,
only
como taxa de mortalidade de câncer ou
on
prevalência
diseases. We will be talking about
de diabetes. Também
cancer
necessitamos mirar a
prevalence or
população que está vivendo com
diabetes.
uma,
We
duas,
need to
três
discuss
condições,
also
porque essa é a
population
realidade
that
de
have
vários
2,
próximos, não?
3 diseases, because that's the
Además
reality
de
of many
eso,
people.
necessitamos dar
Furthermore,
esta
we
mirada
need
más
to
amplia, más
have a
multisectorial
broader
de
look
cómo, ¿no? La
in a
respuesta está
multisectorial
siendo
manner
construida no solo a partir
on
del
how
sector salud.
we are
Tenemos
providing a
diferentes fuentes
response,
de
not only
datos que
from the
son
health sector. We
necesarias, ¿no?
have
La tengo listada
different
aquí a la
data sources
derecha,
that are
a
required.
donde,
To my
a donde
right,
muchos,
I am
donde
showing
la gran
there
mayoría de estas fuentes, o todas,
most
¿no?
of the
Ya
sources,
existen en nuestra
and
vigilancia en
all
salud
these
pública.
sources
Nos
already
falta
are included
hacer una
in
labor
our
más
surveillance. We need
de
to have
integrar y de mejorar la calidad de la
work of
información o la
integrating or
disponibilidad de estos
improving
datos. Pero
quality of
quisiera
information
destacar
and availability of
el uso de
such data.
soluciones
We need
digitales, porque
to
podemos utilizar
highlight the use
como
of digital
vamos a ver en
solutions,
las buenas prácticas,
because
¿no?
as we can see
Las
in good
soluciones digitales
practices,
para nos
we
ayudar en el
can
manejo,
use
nos ayudar
digital
en la
solutions
prevención,
that could help us
solución,
in
pero
management,
también
prevention,
son
promotion,
herramientas
but
que
also
producen
these will
datos,
be
¿no?
tools
Tienen
that
esta
produce data.
posibilidad de generar
We have
información
availability to
estruturada
generate
para
information,
entonces nos ayudar a tomar
and
decisiones,
this
a
could help
mejor
us
orientar
take
nuestras
decisions.
prácticas,
We could
ayudar a orientar
orient
los
our
programas e
practices. We
intervenciones. Entonces,
could
las
have
soluciones digitales
intervention
son herramientas
solutions.
importantísimas para
All
poder
of these
capturar
digital
información.
techniques are relevant
Claro,
to
dentro de uma
capture
estrutura de
information.
vigilância,
Of
queremos
course,
tener
this is
metas e
within
indicadores, não?
um,
E isso
a
é
structure,
importante.
and we
Entonces,
need to have
a captura de
indicators.
información
So
por
collecting
simplesmente capturar
information,
información não é vigilância, não?
just
Só
by
hacemos
doing so,
vigilância
is
quando
not
utilizamos
surveillance.
estes dados para
We
orientar
do
políticas e
surveillance when we
intervenções e
orient
temos
data
várias
and
razões pela qual
intervention,
hacemos
and
vigilância, como
we have
hacer
several
ejercicios de
reasons why we do
priorización,
surveillance.
orientar
For
el
example, we
cuidado.
have
Muchas prácticas
prioritization
van a hablar de
exercises,
eso, ¿no?
we are
Y
guiding
especialmente
care,
hablar de
but
situaciones, mirar las poblaciones en
especially
situación
it's
de
important to
vulnerabilidad y con
see
necesidades
population
desatendidas.
that
Son otras
under
experiencias que vamos a
vulnerability.
mirar hoy.
And these
Cómo
are
llegar a
experiences that we're
todos
going to
en
discuss
todos los
today. We're
lugares,
going to
¿no?
be discussing how
Y
are we going
tener
to
la
reach
información para
everybody.
saber que estamos
And it's
realmente
important to have information
atendiendo, respondiendo a todos.
to show that
Entonces,
we are actually
Entonces,
responding.
barreras de acceso es algo clave para las enfermedades
And
no
of
transmisibles.
course,
Son
this
personas que
is
viven
key for
con
non-communicable
enfermedades crónicas
diseases.
y
There are
necesitan
people that have chronic
cuidados
diseases,
continuos,
they
¿no?
need
Porque hay
continuous
características que
care,
no están llegando a los
and
servicios clave, necesitamos de datos para eso.
it's
Y por
key
último, quiero
to
mencionar lo que aprendimos
find this
durante
information. And
la pandemia,
finally, I
¿no? O
would like
sea,
to mention what
las
we have learned in the
NCDs tienen que
pandemic.
estar, ¿no? El manejo de las NCDs,
The
tenemos que preparar para
management
eso, ¿no? En
for
situaciones de crisis
NCDs
y
is something
emergencia.
that we need to
Entonces,
prepare
los
for.
datos de vigilancia de no
So the
transmisibles
surveillance
deberían
data
cubrir todos estos
should
elementos,
cover
¿no?
all of these
Una área
elements.
muy amplia,
We know that
¿no?
this is a
Con
broader
necesidades
area. We have
específicas,
specific
construimos mucho a
needs.
partir de las enfermedades
We are going to
infecciosas,
start
pero
building
tenemos
lots from
especificidades que son
infectious diseases,
claves e
but
importantes para la
we have
respuesta que
key
tenemos. Quisiera
responses
destacar
according
también
to
que en
the
esta
answers that we
construcción de la
require. And
vigilancia
I
en
would like
salud
to highlight
pública,
that in
no,
that
los sistemas de
construction,
información son
the
aceleradores y son
information
claves para tener la
systems
información
are
disponible de
accelerators to
manera
have available information
oportuna a los tomadores
in
de
a timely
decisión y
manner.
la transformación digital es
And
un acelerador y
the
es
decision
clave para que
makers and
podamos
digital
ser más
transformation
eficientes
would
en
be
nuestro
key
proceso de
for us to
captura y
be more
manejo de
efficient
datos.
when it
Próxima, por
comes
favor,
to
Luis.
collecting data.
Quisiera destacar que
And I
dentro
would
de
like to
este
highlight that
conjunto, ¿no? Hay
within
algunos grupos
this
populacionales que
group,
son importantes. Son La población
we
mayor de
have a
65
population
años, que
that
en la
is
región
relevant. We
aumentaron
have
bastante.
people that are
Estamos numa
older than
população
65
que está
years old.
envelhecendo,
We are a
envelhecemos com
population that
uma,
is
duas
getting
ou três más
older, and
condições,
we
pero queremos
are getting
envelhecer
older
com
with 2 or 3
autonomia e com
more
funcionalidade, não?
diseases. But of course,
Populações
we
que não
want
têm
to
acesso
age
a
better
serviços, que
with
supem as barreiras, que necessitamos chegar
autonomy.
a elas e, portanto,
And
têm
we have also
necessidades
population with
desatendidas, não? Populações
access or barriers
que não estão
to
cobertas
access
em
these
políticas,
services.
porque
We have
não foi possível
some
aplicar uma
populations that
política
are
de base
unattended
populacional para
in
prevenir e
health
controlar, por exemplo,
because
os outros
policies
indivíduos.
were not
Entonces,
able to
esses
be
são
applied
elementos
or
clave que
applied
queremos fazer
in
uma
that manner.
vigilância
So
integral,
these are key elements we need to do
uma vigilância que não deixa
integral
ninguém para
or
trás.
integrated surveillance. And in that sense, we cannot leave nobody
Entonces,
behind.
a UPF ha lançado uma iniciativa
So
que se llama
PAHO
Vital
has launched an
Atención y ella
initiative
tiene sus
which is
objetivos. Y en
a
esta
better
webinar
care for
quiero enfocarme en
NCDs.
la
And in this
vigilancia de
webinar, I would
servicios, ¿no?
like
Una
to
vigilancia que hemos
discuss
tenido
surveillance in
vacío, que no
services.
hemos logrado
Definitely, there was a void.
construir y fortalecer de una
We
manera sostenible.
were not
Entonces,
able
esta
to
iniciativa lanzada por
build
UPF
this in
tiene
a sustainable way.
como
So this
objetivo
initiative
implementar
has the
serviços
objective of
integrados
implementing
pela atenção primária, não? Se quer com essa
integrated
iniciativa
services starting from
melhorar a
primary care.
detecção, o
We
diagnóstico,
want
o
to improve
tratamento, atenção e
detection of
seguimento
diseases,
das pessoas que
treatment,
vivem com
monitoring
essas
of
NTs. Pero
people
para ser
that have
eficaz, porque estamos
NCDs.
falando
But in
desde
order to do
serviços de
that,
derivação, de
we could be
contrarreferência.
talking
Então,
from
para isso necessitamos
referrals,
de sistema
and we need a
muito
whole
bem
system
organizado e
that could be
estruturado para saber que
suitably
estamos servindo
organized
bem
and
essas pessoas,
structured
não? Entonces, la
to
vigilancia
confirm that we're
entra
actually
nesse
monitoring these
espaço, não
people.
só
And this is where
para os
surveillance
dados, para
exists,
screening,
not
pero
only
para
for
também
screening, but
organizar a
also
informação necessária
for
para todo este processo de
organizing
cuidado
required information for all of
se
the
requiere. Próximo,
process
por favor.
that's required.
Bueno, entonces, si vamos más
Well,
específicamente
if
a hablar
we
de
start talking
vigilancia en
about
servicios, no
surveillance
podemos dejar de
in
hablar
services,
de la
we
importancia de
cannot
llegar a los
stop talking
territorios con
about the
sus
relevance
diferentes
of reaching
configuraciones y
territories
formas y con sus diferentes necesidades,
within
¿no?
their different
Entonces, este webinar nos va
extensions,
a
their
mostrar
needs.
algunas de estas
So this
experiencias.
webinar is providing
Cómo
different
podemos, ¿no?
experiences.
Capturar
We need
información
to
para
consider
poder estructurar
how are we
servicios que
going to
responden a
structure
estas
information,
necesidades,
structure
que no
services
tenemos
that
una
would
vigilancia
respond
que
to those
llegue
needs.
al territorio y que llegue a las
How are we going to do that
comunidades,
if we don't have
especialmente las
surveillance that is reaching
que viven con
all
barreras de acesso.
communities
Entonces,
that
integrar
have
las
NCDs?
enfermedades no
So
transmisibles en las acciones de
integrating
vigilancia territorial
NCDs
es clave.
in
Es la
actions
manera
of
que vamos
territory
a poder
surveillance is
conocer
key.
mejor
This
y
is the only
responder mejor a las demandas de las diferentes poblaciones.
we're going to be
Gracias.
able to manage such diseases.
Bueno, y aquí solo compartir con
And I would
ustedes
like to share
una herramienta que tenemos,
a
que
tool that
es
we have.
grupo de indicadores que estamos
Basically,
promocionando en la
this
región.
is
Uno de los
a group of
nuestros grandes
indicators that we're
desafíos
promoting
en
in
la
the region.
atención primaria ha
One of our
sido
main
organizar
challenges
qué
when it comes to
información
early
nos
detection
ayude, qué
is
información es
to identify
relevante
which
para
information
poder
is
responder
relevant
mejor a las no
to
transmisibles. Entonces, quiero
answer
compartir con ustedes esta
in the face of
publicación. Entonces,
NCDs.
esta
I am
publicación nos
sharing this
proporciona
article.
indicadores que nos ayuda a
What
ver
it
cómo
shares
está
basically
el
is
servicio en atención
indicators
primaria,
to
o sea, cómo
see
voy controlar mi
basically
prevención si
information
no
about the
tengo
services in primary care. How am I going to
el
manage care
equipamiento
if I don't
adecuado,
have
cómo voy a
suitable
manejar
equipment?
sobrepeso y
How
obesidad
am I going
si no
to
tengo escalas de estadiómetros para hacer este trabajo.
handle
Entonces,
overweight, obesity,
tenemos
if
indicadores
I don't
desde la
have the right
estructura,
parameters to
¿no?
define
del
so?
servicio
So we
hasta
have indicators
indicadores
coming from
que
the structure of
queremos
the
alcanzar
services
como
on
atención controlada.
the
Ya veo si
indicators that we
quiero
want to
poco solo destacar que hay
reach.
una
And I would
fortaleza
like
en el dato del
to highlight
servicio porque nos da esa
that there's
información
a strength
sobre
there
cómo está el
in this
cuidado,
data
nos ayuda
because
a
we
planear,
understand
pero también el dato de que
care,
el
it
servicio
helps us
representa a
plan,
aquellos que
and
llegaron al
also
servicio.
service data
Es clave que tengamos
makes
en
us
mente
understand
esta información.
how is the
Próximo, por
service
favor.
going. And this is key.
Mencionar que tenemos ahí
Well,
conjunto de
we have
indicadores para la
a group of
atención, para los
indicators
servicios,
for
tanto para
care
diabetes,
and
hipertensión,
services for
tanto en el cuello
diabetes,
uterino y cáncer
hypertension,
infantil, que son
uterine
estrategias
cancer,
y
or
metas, ¿no?
infant
Para nos ayudar a ver cómo
cancer
estamos
as well.
avanzando.
So it
Estamos ahí en
helps
el
us
comienzo
understand how are we moving forward? What I was mentioning in the beginning is that if we have surveillance, but we don't have goals or indicators, definitely we're not going to be able to work. This is going to definitely help us to have targets. Okay, so the surveillance system, particularly when we're working on the field, when we're expecting to reach populations that are farther isolated, we need to consider simple things. We need to consider the needs for caring for non-communicable diseases. These technologies exist to help people. It helps us to detect and to do surveillance, but they have a high potential for capturing data. We need the data because we need to have orientation on our policies. And particularly, I would like to ask you, Silvana, to further review the document that I have sent on indicators, because this is a strategy that we want for aligning and understanding information on how we are responding from primary care services. Thank you. Thank you, Roberta, for this review on conceptual framework and the tools that we have from PAHO, as well as you know that all the tools are available for the website from PAHO on under NCD surveillance. Thank you, Roberta. Now we're going to start with the good practices panel. We have chosen 4 cases out of the 12 good practices that have been published in our website. And if we start with good practices, we can start with Brazil on their topic, innovation in digital health, for afro-descendant communities. I would like to invite Rodrigo Silva Amaral and Dr. João Pedro to start with his presentation.
Então, bom dia a todos. Podem
Good morning,
projetar, por favor,
everyone.
pra
Please
gente.
presentation up kindly. Thank you.
Muito obrigado. Pode
Thank
passar
you
para o
very
próximo, por
much.
favor.
Next
Inicialmente, a
slide,
gente
please.
gostaria de trazer o contexto que o
So
Brasil ele está
firstly, we'd
trabalhando
like to give you
a
a bit of
transformação
background
digital
and
na
the
saúde pública.
situation that
Para
had
coordenar
led
esse
to
processo,
the
em
digital
2023 foi
transformation
criada
in
uma
public
área
health.
específica dentro
In
do Ministério da Saúde do Brasil
2023,
para poder guiar
a
todo esse
specific
processo.
department was
A
created
partir
within
daí,
the
criou-se
Ministry of Health in
programa
Brazil
denominado Programa SUS
so they
Digital,
could
que
steer
ele
the
veio
whole
com o
process.
objetivo de
They
promover
created a
a
project
transformação
called the
digital no
SUS
Sistema Único de
Digital
Saúde,
Program,
de forma
which intends to promote the
ampliar o
digital
acesso
transformation of
da
the unified health
população
system
às
to
ações
improve
previstas no
access to
escopo
its
do Sistema
services
Único de Saúde
and
e aos seus
initiatives
serviços
for
especiais de
Brazilian
saúde.
citizens
É
within
marco
the
nacional que
single
pela
unified
primeira
healthcare
vez
system.
o governo brasileiro
It
ele
is the first
estruturou
time
programa
the
nacional para promover
Brazilian
a
government has launched
transformação da saúde
a
digital e
nationwide
construir
program that offers
ecossistema de saúde digital
resources to
de forma
foster
a
the
garantir
digital
continuidade
healthcare
no cuidado,
ecosystem
com
to ensure
equidade e
continued
a promover
healthcare
uma qualidade
equity
assistencial
and
com o
to
apoio de recursos e da
foster
saúde digital.
quality
Próximo, por favor.
healthcare
So we have
based
support and
on digital
resources for digital
resources.
health.
Experiência
Next slide, please.
exitosa dentro do programa
Just
In
to
order
give
to
you some
start talking
background
about
on
the
our
experiences, we have
activity, we
provided
created
strategic
a strategy called the
Essa ação
model,
estratégica ela veio
which
SUS
is related
de
to
apoiar a
digital
telehealth.
implementação das
strategy
redes de atenção
telemedicine or e-health. Its object and scope
we
was to
have
support the
care
consolidation of
networks
healthcare networks
for
and the
health,
indigenous
and we
people's
also
healthcare
consider
networks
indigenous
by
health through
establishing
guidelines and
guidelines
service
and
provisions
providing
that could
services that
guarantee
promote comprehensive and
continuity
continuous healthcare
on
at
different
all
levels of
levels
care.
within the unified
We
health
have the
system.
strategic planning as
This
well,
activity also
considering
updated all of the
the different
services
health
that are offered
services
within
regarding
the
digital
scope of e-health
health.
throughout Brazil. With the publication and update of these directives in Brazil, the service modalities were expanded. As you can see on screen, the services include teleconsulting, which is both synchronous and asynchronous teleconsulting, in which healthcare providers discuss cases. Normally, a generalist professional accesses and asks a specialist for their specialized opinion to build and design a therapeutic treatment plan for that case. Another modality is teletriage, in which we use conventional triage activities such as risk assessment, etc., but using digital tools. And this is used as a tool to promote an expansion of access. We also have teleconsultation available, in which information and communications are available. We also have telediagnosis, in which a specialist center receives information and they emit their therapeutic opinion, and the healthcare specialist who is managing the case bases his conduct on that.
Avanço tecnológico, né, com dispositivos vestíveis, com central de monitoramento que a gente pode utilizar, e a gente tem cenário mais rudimentar,
can also have another scenario. We
por
have
meio de
this
contato
monitoring
mensageria,
through telephone, through messages. We can follow up chronic conditions. We can follow up patients with hospital. And then we also have the orientation, the communication, mass communication that we have, where we have
surtos, epidemias ou condições que demandam a
the
comunicação dentro de uma comunidade
outbreaks
em larga escala,
or communications that demand areas with messages for this communication. We also have teleconsultation to professionals with the patient to see his clinical condition for users. This is more for users. And we also have teleeducation actions for the professional qualification and teleregulation to support the follow-up. And the last one, that is formative second opinion, materials produced with the teleconsultation with common topics that are prepared, guidelines for orientation for the professionals with more frequent conditions that are received. Next one, please. Now I would like to give the floor to my colleague Rodrigo. Good afternoon. With this first part in the presentation, now we are going to talk about the approach of the intervention that was presented here in this webinar. After what João said, I would like also to add that the ministry started the strategy of strengthening this type of services, telehealth, so that we can strengthen these digital services to increase the access of specialized care for remote and vulnerable populations, to improve the diagnosis in an early manner, especially for preventable diseases. This map is highlighting in blue and in orange a network that we are trying to build, the telehealth network with some institutions that are providing telehealth services. All these group of services that Joao was also mentioning to us. Next, please. I would like to highlight that within this network, we have three main institutions. Here you can see them in green, in red, and in yellow. They are implemented by institutions placed in different locations in our country with the characteristics of providing telediagnosis services, especially telediagnosis. They receive information coming from these different territories that we have in Brazil, and they analyze this information to give a diagnosis to the different territories, to give back this diagnosis to these institutions. This national service of diagnosis act in three different specialties: ophthalmology, cardiology, and dermatology. Next, please. The study that we are presenting here had a specific distribution for vulnerable population. Brazil, as you know, within its continental dimensions, has specific populations that it needs to help in terms of access and improvement of services. That's why this is a very relevant function of the government. Here we can show you how these actions of this Brazilian network with telehealth and the reformulation of policies, this concept of telehealth is being addressed in these specific territories here in Brazil. The first action I would like to show you here in terms of telehealth is an action for indigenous peoples. In 10 states in Brazil, we provided this care. 315 municipalities received the care in Brazil, and we reached 781,253 people in the indigenous populations, communities, and we also serve 349 ethnies. Another specific action was the action addressing the Quilombola ethnic racial group. The Quilombola group is a group that went through the slavery process here in Brazil. They are placed in 7 territories, and we were able to support with the different government actions that are supporting these groups. And we reached 4 municipalities, and in total we had served 10,498 people in these communities. The third group that we served with this study is related to some situations of favelas. Favelas are located in Rio de Janeiro, in this state, in a municipality where we were able to reach 140,000 people in the favelas. This is the results. These are the results and the impact achieved. A structured telehealth network that connects specialists with primary care providers. The telehealth network was focusing on the primary care provision here in Brazil. And another result was the risk classification tools for the dermatologic and ophthalmologic conditions to improve the local care in those territories and also improve the care in these remote populations that it can now receive specialized care without the long distances limitations, because we have a very large territory here in Brazil. The fourth thing is the equity in health, health equity. The services were improved for historically underserved populations, ensuring their right to quality care and allowing them to remain in their communities and territories. And this initiative has also a dimension of equity and also in terms of cares to address the disparities in remote areas. Next, please. The fifth and last item is related to the factors that make it replicable or scalable. The main is the technology transfer and knowledge dissemination. The use of telehealth is characterized by the use of tools that we can use to rate the caregivers within the territory. And these activities involve also remote training that is also ensured by digital training. With this, as you all said at the beginning, this is part of a large activity that is happening in the whole national territory, not only for the activities within specific territories and remote areas, but also as a population, as a whole. The last item is adaptability, replicability, and scalability of this type of actions. These type of actions related to telehealth are strongly adaptable to different systems and contexts, especially in regions with limited access, geographical barriers, or high costs. Brazil is a very large territory. We usually face many difficulties to reach many places, and these strategies can be replicable in public, humanitarian, and rural settings. And this structure does not depend on a physical structure, which allows expansion to other specialties and integration with existing systems. Here in Brazil, we have other initiatives that are replicated in the territory as a whole to use with the diagnosis of the local reality or a specific territory, to use some specialties for healthcare to reduce the time of care provision. All these telecare services are characterized by the support provided by the Brazilian government to reduce this waiting time by patients. Finally, here I would like to show you four representative pictures of the moment that we were experiencing in our work, and I wanted to bring them to this panel to show you that we were using also some actions, ethnography actions, other pictures to send information, where we are sending information for the diagnosis. And a last picture here, the first picture we see here in the bottom, this is the team arriving to this specific territory to provide care to this specific remote population. Well, this was our presentation. A warm hug to all of you, and thank you very much.
Seu áudio está fechado, Silvana.
Thank you. Sorry.
Your microphone is closed.
Mil gracias, Dr. Rodrigo, Dr. João Pedro, por esta excelente iniciativa y como ustedes pueden apreciar, fue elegido como una buena práctica por el impacto que esta iniciativa ha tenido.
Through the impact this initiative has had to be able to add access to specialized services in these rural communities, these indigenous groups, and it is an impressive achievement. And once again, congratulations for this good practice. We will now continue with the order of the schedule, and we will now pass on to the second case in Chile in reference to the use of artificial intelligence to optimize the monitoring and screening of retinopathy and diabetes in the primary health assistance in Chile. I will now invite Dr. Marcela Rivera from the Ministry of Health in Chile and Dr. Fernando Parieg, who is the Director of Ophthalmology of the hospital in Chile. Good morning to everyone. Thank you very much for this invitation. And hopefully we're able to contribute to having other countries increase the access and screening of pathology, which is highly prevalent. Okay, now let's continue. As you all well know, diabetes is a pathology that's highly prevalent. Our country is not accepted from this. Our country, in reference to have this parts in the people over 50 years of age have diabetes type 2, and this is a survey done in the year 2016. Therefore, we believe that currently the prevalence is much higher. Also, those associated to people with overweight or obesity. From these people in primary assistance, we are able to control 1,300,000 people. 80% of people in Chile are controlled in the primary assistance of FONASA. The other percentage has access in a private manner to health services. As a premise in our country, we are able to have screening done of the complications of pathologies associated to diabetes, among which we find diabetic retinopathy. And that is why we are able to establish in a priority manner to be able to have a active search of this complication. And as you are well to see here on the right, we don't have a good compensation in people. PAHO establishes that we should be able to get to 80% of the compensation. However, we are quite far away from that number. And the pandemic made this compensation decrease, the compensation of people with diabetes. We've been recovering this step by step, but we are very far away from getting to the 80% of target, and we have not yet achieved the pre-pandemic indexes associated to the compensation of people with this kind of diabetes. And now we have this high risk of having this complication because, as we all know, this diabetic retinopathy is due to people with diabetes. Next one, please. So then, like we said, diabetic retinopathy is a cause of the loss of sight. People that lose their sight is one of the senses that has more priority for people in reference to when there have been surveys done for the quality of life. It is determined that the vision is one of the health conditions that people would not like to lose. And overall, regarding that people with diabetes have this health condition, they are normally within a work age, and therefore this establishes that we have less life of work still available for us. If we are able to have diagnosis of this, we're going to reduce this risk of losing vision. In Chile, in the year 2005, we were able to carry out a legal advisory, and there was suitability done to the law. And here we are able to have the guarantees of law to be able to have access, opportunities, financial protection, and quality in the attention of health. This is known as Chile. They are basically 90 of the health conditions that are guaranteed in these 4 pillars that we have just commented on. In these pathologies, one of them is diabetes. And diabetes includes the treatment of people with diabetes, the confirmation of diagnosis, the treatment, and the screening of these. Therefore, it was established that any person with diabetes should have a control on an annual basis of the screening of diabetic retinopathy. There are different ways of doing this. We had a very low prevalence of screening, and that is why we try to look for alternatives, given that the amount of ophthalmologists in Chile, and I imagine in the rest of countries in Latin America, was not enough to be able to achieve this kind of work for everyone that has diabetes. If we would only be able to give coverage of the screening of a diabetic retinopathy through an ophthalmologist, it would be impossible to be able to get to the screening that is recommended. And therefore, now I'm going to leave Dr. Barriga, that is the director of ophthalmology in the hospital, so that he can tell you how the screening has been done and also how we're able to replicate it. Thank you very much, Marcela. Next slide, please. Well, the truth is that all of this began from the fact that in one way or another, we needed to develop the practice of detecting cases of a derivable retinopathy. This means that it has a risk of losing sight. In 2005, when the program began, a program that protected people with diabetes, and this was estimated in having 400,000 people in Chile. Right now, in Chile, it is seen that it is around 2 million, out of which 1 million is in the public system. Now, this telemedicine began many years before that. However, it would seem a very good strategy that was detected by young colleagues, together with a colleague that does not work with retins, but they were able to develop an artificial intelligence system that first eliminates this geographic barrier throughout telemedicine, but it also generates a diagnosis in a high percentage of the cases. This makes the use of human resource as efficient. This was developed in the year 2018. In October 2018, this began at a level of the digital hospital. And what was the strategy that was developed? So next one. The strategy always begins from the primary assistance, where the patient with diabetes is in control. At the beginning was for type 2 diabetes. Today is in a universal manner. This would come through a system of taking retinographies. There were two retinographies taken by each eye in a central or from the optical nerve in order for this to pass on to the real red black box, which artificial intelligence is, and that was developed by a system of young engineers where there were two alternatives. The first alternative was for it to say there is apparently not a retinopathy. We're going to see this later on, or that is a medium or severe, and I can see that there are other alterations, and therefore this would pass on to a medical report so that finally there will be the development of the back of the eye for this to be done in the primary manner, and that this can be a way of orienting patients to their level of assistance. Next one, please. This is the way in which, in some measures, we're able to have this digital health expressed. There is an exam done to every person that has diabetes. Here, it could be an adult, a young person, anybody that has a diagnosis for this back of the eye. And if this is altered, it passes on to a specialist. One thing that is important to be able to state is that this system was validated. In an initial way, it was validated by those that developed it, and then later on, considering this context of the pandemic, it allowed an internal validation with a high number of patients, and you're able to have a high sensitivity in the case. Next one, please. This is the production that the program has had throughout its whole development, and it began in the year 2018. Later on, we had the pandemic, which was the year in which there was a lower number of analysis that was done, and then there was a flaw from the platform throughout a month, and then this was taken. And last year we were able to get over 300,000 exams. And right now we are seeing that we have a small limitation in this development in reference to the quantity of exams that we can have done. But here we are quite satisfied with the results that have been done, and in total, we have had 1,450,000 exams throughout the whole development. This does not mean patients. This possibly means around 650 or 700,000 patients, because many of them go in the years afterward to have different exams done. Next one. Maybe one of the most important developments for us is that close to 50% of the retinography, which is about evaluating this system, they were all negative. Negative in a way that means that apparently it is not a diabetic retinopathy. We know that the systems have certain limitations, and we need to think that when we had the validation studies, all of the false cases and negative cases were slow cases. However, we need to consider something that is very important for the suitable functioning of artificial intelligence. It was necessary to be able to have a very clear image that we have here. And at the end, if we see the health services from Chile, there are different percentages in reference to the capacity that this system has of going without disregarding the cases that do not have retinopathy. Next one. And that is why for us it is definitely important to be able to try to train primary assistants. We have 146 primary units right now, in which 142 have telemedicine, so that there could be images done correctly, such as what we are able to see here on the left, the upper lower with some alteration, to be able to have some cases in reference to a dirty filter or some parts and focuses or some non-evaluated case that we do consider can be getting up to 4% approximately of all of the exams done. And of course, it can perfectly correspond to a patient that has a cataract, an internal hemorrhage, but it can also not have the best focus in reference to a system of some mobile, and where it mostly costs to be able to have clear imaging. One of the important things that we were able to develop as well was the development of institutional providers. What does this mean? This means that initially each health service had its own provider that was developing a medical report. And the medical report, although our providers are basically all dedicated to retins, it's not easy. And many times we have to place some image that is allowing for us to be able to see what kind of retinopathy this belongs to. And this has definitely changed. Right now, we have institutional providers that today are able to provide the reports in most of the cases, and we have an analysis that is basically periodic in reference to what can be done and how we can see how we are developing, how long it takes in reference to the development and the congruence that we have in different providers in reference to the cases are valuable or not, which is also a very important parameter of monitoring for us, something that we do on a monthly basis for them. Next one, please. Finally, if we are going to go in all of these cases, this is not a community study as we've done. More or less in 2.5% of all of the patients evaluated had retinopathy with risk of blindness, which means severe retinopathy, proliferative retinopathy, over 90%, they were not being treated. And this means we have a monthly report. It was an important priority for the management of these patients, and we've considered that we have 103,000 patients that are affected with this retinopathy with a high risk of blindness. This is 2.5% of the sample, which is also important to be able to evaluate in different health services. Many times, we believe that sometimes there are patients that are not diabetic, and the 4% of images that are non-classifiable, means we have to be able to analyze the different services, health services, in reference to their behavior. Next one. Finally, we wanted to establish that the automatic screening, we've been able to validate it. It works on the efficiency of the work done by doctors, and we are able to establish
que llegue al factor de riesgo de severa o proliferativa, que sabemos que son etapas tardías y muchas veces poco reversibles.
And that is not reversible. We have been detecting previous cases where we need to optimize the control of the metabolism, and these cases, which are approximately 2.5%, that have a risk of blindness, and we do need for each service to pay attention to this. Maybe we are able to see here in Latin America, today in our country, we have 7 different regions related to the capacity that we have of being able to manage these cases. We have cities that have many ophthalmologists, much infrastructure, and cities that are very far away. That is also a new challenge that we're trying to evaluate because we have the conditions to be able to see which are the patients that are most affected. So please. Finally, it's only about establishing that this whole analysis that is being done is not a community study, it's a sample of what is done here. Community studies that are done here in reference to the reps here in Santiago with Dr. Rudy Vurial, and these algorithms of artificial intelligence definitely have certain limitations. We see in reference to being able to establish this great help and that this can underestimate cases because at the end it's not going to detect one or two hemorrhages that many times are able to be detected and can be reverted. But this is an advanced case that can detect in reference to being able to see the screening. What we are able to see is much higher than we were able to see here because these are very multiple exams and not corresponding to each one patient. Many times, that is what I wanted to show you, and thank you very much for everything that is wanting to be said. Now, Marcela, I don't know if you want to finish the presentation for today. Yes. Like the doctor said, having achieved the improvement of access to people in primary assistance has allowed us to be able to have this part in reference to being able to see this screening. Here, we're not able to get to 100% in reference to primary assistance, but we're around 50% of the people because we've tried to have this screening, and people that are able to see primary assistance are able to have access to this service, which is a team that will be considering here for the new apparatus, which are very good and actually allow us to be able to have equipment that are portable to be able to have here a photograph that is possible of being seen by here by ophthalmologists and to be able to know if this people requires or not a treatment for this. Next one. We believe that this good practice definitely can be scaled. Like Dr. Barria said, right now we have a limit of retinographies to be delivered, but we are working on everything to be able to have the amount necessary to be able to consider assisting 100% of people that need it. This is replicable because right now these are much more accessible. It allows us to be able to have access to these machines that are around $10,000 in Chile. That's a currency that we can all understand. And it is adaptable due to this part in reference to professionals that are trained in Chile, which are medical technologists that take the picture, make the image, and that image is then passed down to ophthalmologists. And this is sustainable because with a machine, we are able to create the pictures of thousands of people. We have this governance which allow us to be able to bring assistance to primary assistance so we can have all of these do this. And ophthalmologists are very much focused on some health centers or some parts of this in African territory. And it's pretty easy actually because a photograph can take a couple of seconds to have this done. This is loaded onto the computers that work on this first filter, and the images that are altered are the ones that are finally analyzed by ophthalmologists, which are the ones that have fewer availability. I think that is the last slide. Oh, no, this one here. And then we are able to have this done throughout the alliances between the private institutions of our country, which are public institutions, Ministry of Health, Health Services, which is a second level, the primary assistance, and digital health. We work together to be able to form this pyramid. Without this, we are not able to achieve this. The final images are of professionals that are using these cameras. We have cameras that are much more modern. Here on the bottom part, we are able to see this is basically like a mobile phone that takes these images. On the right, these are older machines, larger devices, less maneuverable, but the new technologies make it that with a mobile device, we are able to take the photographs for the retinography. She's a medical technologist from San Antonio that was able to deliver the photograph and the capturing of retinography. Thank you very much. And our friends to being able to do this, given that it's a technology, it's quite accessible. Thank you very much, Marcela. Fernando, for this presentation regarding the use.
artificial para la retinopatía diabética. Y realmente es un logro increíble, ¿no? Para
It is
utilizar la
a challenge
tecnología
for
para
us
detectar
to
la
actually use
retinopatía
technology
y
for
derivar los casos
diabetic
al
retinopathy
segundo
and
nivel, ¿no?
refer the
Ponerlo
cases in the
en la
second
atención
level,
primaria de salud de
as
ese tipo
well
de
as having
instituciones y
primary
espero que se pueda
care
replicar en otros
assistance.
países en
Congratulations,
la
we're
región.
hoping to
Muchas
be
gracias.
replicating this in
Bueno,
other
seguimos
countries in the
con
region.
el programa y
And we will
pasamos al
continue
siguiente caso,
with
que es de
the
Argentina,
program. We're going to continue
sobre
with
la
the next case, which is the one of
informatización
Argentina,
de las teleconsultas del programa de emergencias
regarding
cardiovasculares. Nos
information
acompaña el doctor Eduardo Esteban
on
Lempen Ibáñez,
cardiovascular emergency
el
program
médico
on the Tucumán
cardiólogo
network.
del
I
Ministerio
would
de
like to
Salud de la
invite
provincia
Eduardo
de
Lempen
Tucumán
Ibáñez. He
en Lima.
works in the province of Tucumán and in medicine management. Yes, thank you for inviting me, and I will talk about the topic of my talk related to the strengthening cardiovascular emergency program in Tucumán. So to get you into the context, we know that cardiovascular diseases are the first cause of death in the world and in our region. And is one of the main causes is the acute myocardium arrest. And according local records, we have seen that we have delays in caring for this disease, and also we have unsuitable management in the first level of care. In the face of this problem, our challenge was to implement local strategies that would enable to follow recommendations and guidelines for managing such diseases. Therefore, the objectives included implementing a program for attention of cardiovascular emergencies in the network with an integrative approach, combining urgencies and cardiovascular emergencies care, and training the personnel on call. We are talking about doctors, nurses that will work on call throughout the different networks, implementing telehealth for continuity and assistance care, and implementing telehealth for continuity and emergencies, articulate public and private care on emergency, registering suitably by evaluating indicators and quality of care. As main actions, I think that you can see that in Tucumán province, this is located to the northeast of Argentina, and from the point of view of the health system, the province is divided in 4 areas, 4 programmatic areas. We have the centers of reference. We have the coronary unit, cardiovascular unit. We have other areas that are farther away from these centers of reference. We have the south area and the east area, and the different areas are distributed in more than 300 existential system in first level care units and second level of care. And our strategy, our intervention consisted in selecting second care hospitals that are not close to their center of reference, to have cardiovascular nodes with a better capacity for resolution, and implementing resources. We have increased our management of such pathologies. We have included cardio defibrillators, infusion pumps, EKGs. We have included medication. We have included thrombolytic resources for treating heart attacks, for example. We have included as well resources for video conference. We have included cameras, for example, as well as on-call personnel. We wanted to include access to technology that would help us have more fluidness and coordination in the network through mobile devices. We know that the personnel on call can provide consultations for the cardiologist by having a telehealth consultation, and they sent information of the patient, and they sent information of the EKG to the specialists. And also in the cardiovascular nodes, we are able to perform video conferences. That means that through a website, we select all of the cardiovascular nodes, and they could be intercommunicated with the core, with the center assistance unit, and the specialist or the cardiologist can see the heart rate, saturation of oxygen. We can coordinate with the doctor that will be part of this clinical assistance, and we also have informative record of all consultations to evaluate indicators of care. And another action would be the provision of actions for referrals between hospitals. We have an on-call cardiologist, and role is to receive information, and this enables us to guide the personnel on call in all the networks in the province according to the complexity of each center. For example, if we're talking about low complexity centers, they coordinate and they have suitable management for proper referral towards these nodes. And sometimes they coordinate through video conferences. We could handle diseases that could be of high risk for patients. We could provide treatment with thrombolytics. We could as well coordinate activation of ambulances as well. And we could see what's the proper reception of the or handling of the patient at the same time. And we have continuous training because we train the personnel on call, the doctors and nurses as well, and well, according to the complexity of each center. For example, the doctors should be able to know about asynchronous defibrillation. All of the nurses manage the EKG. They can prepare some medicine, among other things. Among other things, we have had agreements with the university in the province of Tucumán and with the Ministry of Health, and we have provided training for the soon to be graduated doctors of the program, and many of them were interested in working in these units.
Bueno, ahora les voy a mostrar un caso clínico que trata de resumir todas estas acciones en un caso clínico, que esto se trata de una paciente.
And this is a clinical case of a patient, 60-year-old patient.
En este caso, el Hospital de Aguilares.
And we have the El Aguilar Hospital. It is farther away, more than 60 kilometers of reference. And the patient was had a critical condition. There was a tachycardic condition, as you can see in the register there, and there were no personnel that were trained to handle such pathologies. If that happens, what the guidelines say is that we cannot transfer patients to, or have a referral to the patient. We need to have some sort of therapy or treatment
Aquí
to
les voy a
stabilize the
mostrar en el
patient
video cómo
prior
en
or
este
before
día a
moving
día
it.
el
I'm going to show you
cardiólogo
how, with this
guía y
strategy, the
premedicina esta
cardiologist
intervención.
is guiding with a video conference, he's guiding this intervention at the moment.
Aprieta las paletas el botón de descarga. Abramos el oxígeno y miremos el monitor. Ahí han revertido.
So the doctor is providing some guidelines there. For example, she's saying to look at the monitor. She's providing guidelines through the video conference. In the meantime, she's mentioning to continuing providing oxygen for the patient. We need to continue monitoring because the patient is asleep. And she's guiding them and asking for a EKG.
Bueno. Bueno, siguiente.
Well,
bueno, ahí en el video pudieron ver cómo un caso, cómo el nodo cardiovascular
I'm sure
tiene
that you're
mayor
going to be able
capacidad
to
de
see
recibir
how this has a
el centro
better
alejado. ¿Sí? Con respecto,
resolution
esa paciente
for
fue
these
estabilizada,
cases,
se
and
dirigió a la
the
reina,
patient
se
was
estabilizó y fue derivada al
stabilized
centro
actually.
de referencia,
And
¿sí? Actualmente. Bueno, con respecto a los resultados,
with the
aquí les traigo un
results,
análisis de
basically, I
casos
wanted to show you that I have
año, ¿sí?
an
En el
analysis of
periodo de
cases
enero a julio del
in
2025
this
son pacientes asistidos en
year,
o
January
nodos
to July.
cardiovasculares.
And we
En
have
lunes
all
de
of these patients that were
1.331
taken care
casos,
of in these
podemos
cardiovascular
observar que
notes,
el
and we can see
76% de los
that
casos no
76%
necesitó
of
ser
the
derivado a un
cases
centro de referencia
was
y
not
sí
required
pudo
to
ser
be
conveniente en el
referred to an
lugar.
emergency center. They were able to
El
receive care in the
16% del
area,
total fue
and
derivado al sector privado y solamente el 8% a
only
los centros de
8% were
referencia. ¿Sí?
derived to
Aquí
referral
podemos ver cómo la
countries.
coordinación optimiza el manejo en el primer lugar de atención y
And you
también
can see
cómo la
how this
articulación con el
coordination
sector
optimized
privado a
management in the
través
first
de
level of care, and
la
how there's an articulation
verificación
with
de
the
la
private
cobertura
sector,
médica permite la
verification,
optimización de
and
recursos
enables
con
optimizing
impacto a
these
la gestión del
resources
gasto público.
with less impact
Y bueno,
in
con
public
una mortalidad en este
expenses.
caso,
There
en
was
este
a death
periodo,
rate
se había establecido con una mortalidad de menos del
of
1%.
6
¿Sí?
fatalities, and it was less than 1%, as you can see.
Con respecto a indicadores de
When it
calidad de
comes to
atención
indicators of
para el
quality of
infarto agudo del
care
miocardio con elevación de
for
SMO-TCT, les muestro un análisis de
myocardium
casos
acute
de pacientes que fueron
cardiac arrest, I can
derivados al
show you
hospital
some
público
patients
de
that were
referencia.
derived to the
Es decir, aquí
referral
están
hospital,
incluidos los pacientes derivados al
and
sector
we are not
privado, ya que
including the
perdemos los datos
patients of the
durante la
private
internación en el
sector
sector
because
privado.
we
Y
could
bueno,
lose
esto es
some
durante el
data,
periodo
basically.
de 2022
But
en la
this is
actualidad.
throughout the period
Podemos
of
ver también unas
2022, and
comparaciones
we
de
could see
tiempo
some comparison through
donde
time,
con respecto a la atención
actually.
del infarto, siempre
Uh,
el gol estándar
and
es el
the
tratamiento con
goal
angioplastia
is
siempre y
to
cuando se
have
realice a
a
tiempo
treatment with
adecuado. Cuando los
angioplasty.
pacientes se demoran
When
en traslado
patients
de
take some
tratamiento
time
de angioplastia,
with
pierden
the
beneficio, ¿sí?
treatment,
Es por eso
they
que
lose
la población más
the
vulnerable
benefit.
son las que viven en centros alejados, porque siempre llegan tarde a la angioplastia.
Because
Entonces, para
sometimes they
ellos,
are not
la
arriving
alternativa
soon to the
es realizar
angioplasty.
el
So that's why for
tratamiento
them,
en
the
el
alternative
lugar
is to provide
con
treatment on the
trombolítico
spot with
y
thrombolysis.
luego derivarlo post-trombolisis a los centros para programar un cateterismo dentro de las 24 horas. Esa estrategia se llama fármaco invasiva. Y en líneas
And
generales, como
this
ustedes pueden
strategy
ver,
called a
el tratamiento con
pharmacoinvasive,
trombolíticos y
the
fármaco invasiva
treatment
está en
with
aumento gracias
thrombolysis is increasing as a result to
al uso
the
de telemedicina. Nosotros podemos implementar, comenzamos a implementar desde diciembre del 2023 hasta ahora, Y también otro indicador importante es el tiempo total
Another
isquémico,
indicator
el
is
tiempo desde
also
el
the
inicio del
time
dolor
from the
hasta que
beginning of
reciben una
the
terapia de reperfusión
pain until
peritoneal.
receiving
Con
therapy of
angioplasia o
hydroperfusion
trombolis,
with
aquí
angioplasty or
también nosotros
thrombolysis.
estamos trabajando
And
fuertemente en
we are
esas zonas
working
vulnerables, esa población
very
vulnerable de zonas alejadas,
strongly
donde
with
el
this
tratamiento con
vulnerable
trombolisis
population.
permite, como pueden ver
We
ustedes,
are
un tiempo total
enabling a
isquémico de
treatment with
180
thrombolysis because
minutos
it enables an
en
ischemic total
comparación
time of
con el tiempo
um,
total de los pacientes que son derivados para
120 minutes.
angioplastia. Ahí vemos que hay una
Compared to the
reducción
total time of
significativa
patients that are derived for
en el
angioplasty, we
grupo
have
de
seen that there
trombolisis.
is a
Así
meaningful
que
reduction.
ahí se observa un
And
trabajo que
we
estamos
can
realizando
observe the work
y
that we're
llevando, tratando
doing
de llevar
and
equidad a
trying
toda la
to
población, ¿sí?
provide
Con respecto a
equity
la
conditions
mortalidad,
for all the
veníamos con
population.
un 11-12% y
And we have
actualmente
11 of
disminuyó un
12%.
poco más del
Currently, this has
9%.
decreased more than
Siguiente.
9%.
Aquí también en este gráfico observamos el trabajo
In this graph,
que
we are
estamos
able to see
realizando
the
en las
work that
otras
is being
cardiovasculares
done
en esos
in reference
segundos
to these
niveles
hospitals at a
alejados
second
del centro
level
de
that are
referencia,
quite further away from the
donde el
center of
tratamiento
reference, and where
trombolítico
we
de
are
infarto
able to
agudo
establish here,
guiado por
and this
telemedicina
linked by
por el cardiólogo
telemedicine in
coordinador.
reference to the
Esto,
cardiologist.
como les dije,
And this, as we
comenzamos esta
mentioned, we
estrategia
are
en
basically
diciembre
seeing
del
this strategy
2023 y
in
ustedes, como
December
pueden ver
2023. And as you
en la
can
línea
see
azul,
here in the
en el
blue
año
line,
2024,
in the year
cómo
2024,
fue aumentando
how all
estas
of this was increasing
intervenciones
in reference to these
con
interventions.
22 casos
The
el año
22
pasado y
cases last year,
cómo en
and
comparación con este año,
in
cómo
comparison with
también
this
hay
year,
una
how
mayor
at the same
adherencia
time there
ya
was
en
more of an
julio de este
adherence
año.
in July this
Prácticamente
year,
estamos
which
igualando el
basically
total
we
de
are
casos del
actually
año
seeing the
pasado,
total number
con
of
una
cases.
mortalidad del
And this has to do with the
4,8%.
mortality
Murieron
of
fallecieron dos
4.8%.
pacientes,
We
uno
had
en el
two
lugar y
patients
uno
passing away,
de los nodos
one
con bloqueo
in
completo y el
one
otro con
by
un
complete
considerado
blockage and
mayor
one due to
hospitalización
more
nivel del total de los
blooding in
casos.
reference to the
Siguiente.
hospital. Next one.
En base a todo esto, en nuestra
And based
experiencia,
on all of this
nosotros
in our
pensamos que el
experience, we are
apoyo del
thinking
Ministerio de
that the
Salud
support of the Ministry
local
of
a
Health,
través de la
local
creación de
Ministry of Health,
programas
throughout
PAHO
the
de
extension of a
solución es
program with
lo
the
que permite
resolution
el acceso
is
a los
what allows us to
recursos
be able
y
to
la
have access to
sostenibilidad en
resources
el tiempo.
and the
A
sustainability
su
within
vez, el
time.
uso de
At
la
the same
herramienta de
time, the use
telemedicina
of the
y,
telemedicine tool
y la
and
capacitación
the
continua del
training,
personal de
continuous
guardias de
training of the
emergencia
staff of
son,
the emergency room
consideramos que
are
son herramientas
considered
que
to be
pueden estar
tools
al alcance de
that can
todos
be
los
in
sistemas
the
de
scope
salud
of all of the health
para su
systems
replicabilidad.
for the
Sí, la telemedicina es
replicability
importante
in reference to
para darle
telemedicine and how
fluidez al
important it is to be
establecimiento
able
de
to
la
give
red
it
y la
fluidity,
capacitación
fluidness in
continua
reference to the
del
continuous
personal
training
para
of
adherirse a los
staff
protocolos
for
de
adherence to
trabajo
the protocols
que
of
deben estar
work and
adaptados
that should be
a
adapted
la complejidad de cada
to the
centro asistencial.
complexity of each
Siguiente.
assistance center.
Para finalizar,
And to
tenemos que
finish,
la integración
we must say
tecnológica
that
y
the
el trabajo en
technological
red
integration
posibilita
and
la articulación de todos los
network
sectores
work
involucrados,
makes it
fortalece
possible to
la
have the
capacidad
articulation
de
of all
respuesta del
involved
sistema de
sectors.
salud.
It
De este
reinforces the
modo, se
capacity of
optimiza la gestión
response
de
in the health center.
emergencias
In this
y
way,
la
there is the
continuidad del
optimization
cuidado,
of emergency
aportando
management, the
eficiencia,
continuity of care,
calidad y equidad
supporting
en la
efficiency,
atención de toda
quality,
la
and
población.
equity in the attention to the
Siguiente.
whole population. Next one, please.
Muchas gracias.
Thank you very much.
Y muchas gracias a ti, Dr.
Thank you
Lempe.
very much
Muchas
to you,
gracias
Dr.
por tu
Lempe. Thank you very
liderazgo,
much
por
for your
ese gran
leadership,
esfuerzo
for this
de
very
la
great
telemedicina
effort
en emergencias
in reference
cardiovasculares.
to these
Realmente es
cardiovascular
un logro por
emergencies.
todo
It is
el
definitely a great
Tucumán, ¿no?
achievement in the
Y
whole province
también
of
es un buen
Tucumán,
ejemplo
and
para
it's also
otros
a great
países en la
example due
región
to
de
other
cómo se puede
places
utilizar
in
no
the
solo
region and how we can
la tecnología de
use not only the
telemedicina
technology of
para esta
telemedicine
emergencias
for
cardiovasculares, pero
cardiovascular
también
emergencies,
esta
but
organización en
also this
red, esta
organization and
capacitación
network
continua,
training,
el
continuous training
monitoreo de los
in
datos
the
para ver el
monitoring
impacto y
and the
los
data, how we
resultados
see the
obtenidos.
impact
Así que
in
muchas
reference to the
gracias
results
por
that have been
estación
obtained. So
Tucumán.
thank you very
Sí,
much
gracias a
again.
ustedes. Gracias a ustedes
Thank you.
y gracias
Thank you.
el apoyo
And
importante
thank you
del
very
Ministerio
much
de
for the
Salud
continuous support of the Ministry of
inhabilita
Health. As we
para
said,
el
it
acceso a los recursos, el
paralyzed
apoyo
access to
permanente y eso es lo que
resources,
abre camino a
permanent
Sí,
este
support,
trabajo.
which
Gracias.
sí,
gives the
sí,
way
son
onto the
las
thank you very
relaciones
much. Yes, it's
institucionales.
the
Gracias.
institutional relations. Thank you very
Bueno,
much.
seguimos con
And now we continue with Guatemala. The case is called Canaxic. It is a sanitary tool that is used for the early detection of hidden kidney disease in Guatemala. I invite Dr. Santiago Dorales, head of susceptive treatments and renal and kidney function in Guatemala. Go ahead, Dr. Santiago. Thank you very much for the invitation. What we are going to now say here, after this very much excellent response in the region, the experience that we had with this application in reference to these tools that crosses information that is normally available in all of the health attention systems, but try to do it in an innovative way, in a scalable way, in order to be able to facilitate the following step, which is about seeing this in reference to this chronic part, considering this for the Institute of Guatemala and Social Services for the product and the project. Next one, please. Now going into context, a chronic kidney disease, which is what we are focusing here on this for this tool, for the report of the year 2019 established that 850 million people live in the world with this pathology, and for 2040, this would be the fifth cause of loss of life. At the same time, the chronic kidney disease is predominant in reference to the increase of cardiovascular death in reference to the non-communicable illnesses, and it definitely constitutes a determinant factor for the coverage of universal health. In reference to this, it's very much asymptomatic and it may take onto terminal stages in a frequent manner. Therefore, the most useful strategy to be able to continue with the patients, to be able to find them and work on them suitably is to detect them on time. Because by not having symptoms, normally patients are making reference to the clinical consultation due to symptoms of the illness. There's very little to do, and the patient is condemned to therapies of kidney replacement, hemodialysis, and peritoneal dialysis, and with very little prevalence, the possibility of transplants. In particular, in Latin America and the Caribbean, this general situation has some determinants that are very much specific because it has a prevalence that is above 10% with growing rates of hypertension and mellitus diabetes, which are the main ends of chronic kidney disease, and the mortality per se in reference to this has grown 35% in the last 20 years in the region, and it's one of the growths of mortality that is highest in the country. Therefore, we are arriving late to see the patients, and there are many difficulties in reference to having this done to the diagnosis and also treatment. What happened in Guatemala, we were actually developing this project, a MAX project, which is a project seen with the social health of the country in Guatemala here. It would not exceed 430 patients per million people, and in the social insurance, it was also an amount that was a little bit higher. It will definitely have access to the last chain of the last stage of pathology, which is the entrance to pathology. So we wanted to try to develop a new tool so that this highly prevalence will allow us to be able to detect patients in a more earlier manner. And this in the project that lasted 5 years and that ended in 2023, besides implementing a network of 27 centers in reference to the whole country in a decentralized manner, it also gave the support to the strategy of the institution of the Integrated Health Center in reference to these parts. Next one, please. And the objective was to be able to develop a tool with data that was available in the health system, or at least in the system that the institution has. And these are possibly in all of the health centers in reference to the presentations, the determination of a plasmatic creatinine of the patient, the date of birth of the patient, to be able to have the calculation of age, the identification of sex data that is quite important to be able to register in each location, the place of residence and the center of attention where we are able to develop the plasmatic creatine where we are able to have this assistance done. And to this date, we are able to create estimates of the index of filtering and to be able to try to have an estimate of kidney chronic disease in the area of Guatemala. This is seen from stage 1 to stage 5. The slightest situation until the most severe one, which is stage 5 in reference to the reduction, and then we are able to integrate these results to the data of clinical evolution to be able to generate a location for potential patients, knowing that this intervention definitely generates diagnosis that needs to be confirmed by a clinical consultation and a clinical consultation in time that's starting by this detection in reference to this. This definitely affects, potentially speaking, these vulnerable populations when there is a lower level of education and more poverty. There is a higher prevalence in reference to this throughout the whole world. This generates lack of equity and access in reference to this part. There is a lower access to everyone in reference to this region and public health, and due to the area of residence, the rural area have a lower possibility of access, especially for these products in reference to the region of South America. We are also able to establish this in the Mesoamerican area with indifference to the area of diabetes or hypertension. This goes to patients between 40 and 60 years old. This affects young men in rural work or situation of non-registered work. And therefore, the early detection would allow us to be able to handle in a suitable manner these patients, especially in the interaction of the specialty in nephrology with the first level of assistance. And this is one of the things that has been recently seen by the resolution number 67 of the World Assembly of Health and the WHO to be able to integrate this in the list of non-communicable diseases and primary assistance. Next one, please. What we were able to do now as concrete actions of this good practice, which has been selected, was through the important reference to what allowed us to be able to obtain. This has allowed us to be able to obtain this work was done throughout October 2022. We were able to build a database where we were able to have the incorporation of the total of 3.1 million of registers of plasmatic creatinines affected in 10 laboratories that were working at the Institute, and all of them would use the same technology for analysis in reference to this. And that data at the same time from this base was combined with the unique register of affiliated people in the Institute, with were 5.3 people between January 2017 and October 2022. Throughout 7 years, this whole previous analytic, with all of the patients linked to these analytics. This was all segmented in reference to the information to be able to obtain the filtering or the calculation based on this data. And we're able to identify these through the equation, modification, and renal disease being validated for the past 25 years for the estimates of filters specifically to be able to detect over 500,000 people, of 527,000 people with 18 years and above, out of which 441,000 had a determination in an ambulatory manner, first and second level of assistance. With this, we are able to interact together with the screening and validation of this data, a table that would show 4 levels or 4 categories. One, the level of measurements of plasmatic creatinine to be able to see the efficient use of resources and how many measures are done, if these are defective or not in pathologies. Then the estimates of the filtered indicators. Then another tool that this had was the maps of georeference due to different levels of a filter index. And finally, in those patients that had over 2 creatinines throughout the follow-up period, a clinical follow-up to be able to see the evolution, whether the deterioration of patients that have not had the intervention, and also how patients could work with a specific intervention. Next one. And here, this was the first one that had to do with creatinine. As we can see, the distribution by gender, although there was more priority here, in reference to affiliated and benefited, and in reference to the masculine gender, access to this was quite similar between both genders, in reference to the accessibility, being able to do this, in reference to being able to guarantee this. And as we can see, when there is the increase in reference to the age of patients, we're able to see here this on the bottom left, and the value of creatinine is going to be increased. This was translated in reference to an equation, and we're able to see here this is much lower in reference to this part. Next one. These are the creatinines done by the attention center, also to be able to show this as a strategy in reference to the area in Guatemala have not been considering the higher level of determination. So we were able to determine that the majority of these were included in reference to the metropolitan area of Guatemala, where we also have the largest amount of the population. But it also showed some places in other places in the country where it was possibly necessary by retribution of the health centers and the specialization in nephrology to be able to see the levels that are needed. And it's important that throughout 7 years, there was also a group of 80,000 patients that had had two determinations of plasmatic creatinine or others. And in reference to being able to see this part in reference to the estimates to creatinines, and as we have seen here, the quantity of patients in reference to this part seen according to categories over 60, which would be a normal filtering, and then the filterings that need the assistance in reference to nephrology, and also the final stage, which is G5, grade 5, that requires substitution with dialysis. Next one, please. What we are able to find here is that in all of the creatinines, we are able to choose which ones are the creatinines that are ambulatory. Next one, and we are able to identify here a total of 7% of patients with deterioration. Next, previous one, please. The deterioration of filtering that required the intervention of a nephrologist. As we're able to see here in yellow, these are the patients that need to have an interaction with them. And here we have the identification of them, but it was very much seen. It's a differentiated by gender. There were already over 5,000 patients that had to enter the dialysis in reference to being able to see here from the part, and in reference to being able to establish this part. And we have this indicator, we did not have access considering that they were not detected to being able to see this part. And we have this, and what we were able to do is to be able to have a follow-up in reference to this end. And here we are able to see here this in the effect of the pandemic in the year 2020, 2021. Here we are able to see the amount of analytics in reference to this, but those that are in a watercolor are the patients that have more deterioration, and that we were able to see here by a concentration in reference to the health center. And here in gray, we're able to see this because from the 80,000 patients that we had more than two creatinines, we were able to determine the time of evolution of one stage to another. And as you can see, we need 38 months to pass from 3B to maybe 4, which would be basically pre-dialysis. And the patients that are here in pre-dialysis that need to go into dialysis would need to be seen from the idea of evolution in reference to being able to see this access to the Institute of Pathology. Next one, please. Next one. And this was the autonomy that what was said here, and in reference to being able to establish this part, considering just in one place in Guatemala, in reference to being able to see the patients that are in black, which are in stage 5, in reference to establish this. And here There is a hospital here from the Hospital of Illnesses of the City of Guatemala, and this was translated onto here. That is why this is in reference to year 21 and 22 in reference to autonomy and how this was seen how we would have the distribution of patients per service in reference to the severity of the pathology. Okay, next one. And these are the maps of georeference that was done here. Here we have mostly 60 filters in reference to this part, and in reference to these laboratory centers, and we have a high concentration of measures of creatinine and filtering to have over 60 in the area of Guatemala. In reference to being able to establish this. And here we're all able to interact on this in reference to being able to establish this and to have the amount of patients in reference to how we have this and the patients that we have. And to the pre-dialysis here in reference to being able to establish this territory. In reference to this part established and the situation in reference to this distributed throughout the whole country, but with specific centers in places, although the strategy is how we are able to characterize this in the health center to be able to see the assistance provided. Much of this also belongs in reference to the centers. And the last part here has to do with the possibility of being able to work with patients that had more than 2 creatinines in reference to the follow-up on a long-term basis. So patients were anonymized. We would just cross the numbers of patterns. We would identify the age, the sex, when we had done the last creatinine and the filtering in reference to the creatinine that is calculated, and also the stage has been defined. And this has been done throughout the whole evolution of the patient. This was installed and it could be seen directly onto the clinical histories of the patient according to what the institute has. This is a case of a patient that was improving throughout time due to the intervention, suitable intervention of these parts. Next one, please. In these last case, to be able to see an increase in creatinine in reference to being on the left with the deterioration, and this has to do with a patient that in 30 months or 38 months would be needing dialysis. And just to start finishing, what we would hope is that this is the way of being able to detect people that would have a filtering level of less than 60. This is the most cost-effective strategy to be able to try to manage this pathology, and it has a high cost in its last end. In reference to being able to establish this among patients of 50, in reference to being considered this with a nephrologist and to this end. And in reference to being able to see this part, and this has a reduction of the cost of transplant, and it also have clear improvements in reference to survivals to this. We were able to have the amount of data that we received. We were talking about 5 million affiliated person, over 7 million in reference to those parts. And at the moment of this, there was no any tool in reference to being able to see this interoperational costs until we have this experience, which at the end of the day is replicable. We just need to be able to upload this information that generates this whole data, for which it could be replicated in other systems that are sanitary as well. Next one, please. And we're able to maintain and update this information. And in reference to this tool, there's no cost affiliated to this. We just need the information of creatinines and affiliation in reference to many of these being in the places. And we're updated this in reference to a tool to the modeling of this end, to being able to see in this part in reference to being able to generate an improvement in the interaction of data. And all of these are things that can be downloaded and used in a simple manner. Next one. Here, learned lessons, fundamentally speaking, cohesion in reference to this part. And here to be able to collaborate in reference to this, and this are not able to see the individual initiative of an institution, but there has to be a cohesion with the associated and database require work of review, and definitely to disregard data that are anomalous. And in reference to this part, and in reference to the early detection of patients that are integrated in reference to the actions on land, but overall to be able to have an idea of where the patients are located, considering human resources that we have available in these territories that allow us to be able to use these telemedicine tools as it was shown in the previous presentations. Here to be able to present this and to be able to consider the development in reference to this part and to United Nations of Guatemala. Next one, please. And just to be able to finish, we are meeting the following and in reference to the objectives of sustainable development. In the 17 objectives and targets, we had met 4. Next one, please. And none of these things cannot be done without the work of the team, like licensee Rojas, Priscilla Flores, Pablo Reyes, Jose Javier Saravia Mata that designed the whole interaction. And as part of the team of nephrology, Dr. Harold Gil Garcia, and also myself that collaborate in this end. Next one, please. In reference, what does Kanoshik means? Kanoshik means to search. Those patients do not search for are never found. And that was the idea of this tool. Thank you.
Oh, gracias a ti, Santiago. Felicitaciones, excelente herramienta, excelente.
Thank you very much. Congratulations. It's a very good tool with excellent use of information to be able to monitor people in a very early manner, to be able to have an early detection of this. And we were able to see also the tables and everything in reference to being able to see the data, to be able to monitor within time in different levels. Congratulations. And this definitely motivates people. That's the idea. Thank you. I think that we have gotten to the end of this webinar, and I would like to thank all of you for your participation, for your attention. We have over 300 people here connected today, and hopefully we have given an overview of all of the best practices that are being delivered in the region in telemedicine, in the use of artificial intelligence. And we believe that we've inspired on the replication of each one of this, and to be able to improve in the surveillance in reference to the prevention and control of people with non-communicable diseases. Thank you very much again. We'd like to invite you to visit our website to be able to review more cases of best practices and all of the tools that we have from PAHO to be able to verify all of this. Thank you very much to all of you again. Congratulations. I will see you in a following our virtual opportunity of PAHO. Thank you. Goodbye.